I'd also like to talk about how we manage bradycardia because there are some nuances to this. So we know that we have a couple of things available to us when we're looking at someone who has a symptomatic bradycardia. And the ALSPCS basically defines that as someone who's having symptoms of poor perfusion and hypotension associated with a bradycardic heart rhythm or heart rate less than 50. So we have a couple of options. We can position that patient. We can provide a fluid challenge in the form of a fluid bolus. We can provide atropine. We can consider pacing, and then we can consider dopamine for those patients. So there's a lot of things available to us that we can consider when we're looking at managing a symptomatic bradycardia patient. So when we make those decisions, we're really looking at stability. So I try to put this in the form of a flow chart to kind of figure out, well, how stable is the patient? How am I making these decisions? And what am I doing up front? Now, this is going to assume that we've managed our typical ABCs. So we have done a primary survey and we've managed the ABCs effectively on this patient, including things like oxygen and airway management. Now, that being said, there's a couple things we have to think about. One is the effective positioning, and this is often downplayed in the symptomatic bradycardia patient. Positioning and fluid bolus alone is effective in around 40% of patients who are experiencing symptomatic bradycardia. So when I look at how we're going to respond to these patients, one of the first things that we're opting to prioritize is, can we lie that patient in the supine position, and can we provide them with a fluid challenge in order to support the contractility of the ventricle and hopefully gain output. So in 40% of patients, we see a decrease in symptoms and an increase in cardiac output or blood pressure. So a decrease in symptoms and an increase in blood pressure. Now, that being said, we have to be aware of some of the risks to this. In terms of repositioning the patient supine, typically very little risk, takes very little time. There's no reason why we wouldn't be doing that on all of our symptomatic bradycardia patients. Fluid bolus takes a little bit more time. We know we're looking at potentially, a 7 to 13 minute IV start, and we need to be considerate of that. So the one caveat to this that doesn't fit well in this flow chart is if this patient is pre-arrest and we don't think that they have time for the IV start, we move all the way through this pathway right up to pacing, and we go from there. But in the majority of our patients, we're typically entering this call before they're truly at that full pre-arrest state. So they may be unstable, so they may be a very sick patient, but not often are we walking in as they are truly in the process of dying. So if that's not the case, so if we see this patient who is acutely ill, but we don't believe they're pre-arrest, these two things are usually going to be the non-negotiable. We're going to reposition the patient supine, and we're going to consider giving a fluid bolus. That doesn't mean that I'm not moving towards something like pacing. So perhaps I'm starting the IV and the fluid bolus for this patient while my partner is doing a 12 lead, putting the pads on, getting my atropine out, so that I have a really fast progression if needed to these other steps. So the one thing we'll position right up front here, which is typically going to be non-negotiable, is the repositioning of the patient and the consideration of a fluid bolus in the non-pre-arrest patients. The caveat is that if they're pre-arrest, we're likely going to move uh, right down to this unstable pathway. So then we have to determine stability, and this is an interesting concept because it is already an unstable patient. We have a symptomatic bradycardia patient, so someone who is hypotensive, who is bradycardic. So really what we are talking about in terms of stability is hemodynamic stability. So yes, we understand that the patient is acutely ill, that they're already going to be classified as unstable by being a symptomatic bradycardia, but how quickly is their hemodynamic stability progressing? Does this patient have time? And what we're going to use to make that justification is basically an assessment of that hemodynamic instability. So how unstable are they from a hemodynamic perspective? And we've talked about this a bit. One of the first things we're going to look at is their level of consciousness. Is the patient alert oriented? Are they agitated? Are they lethargic? Are they obtunded? A reduction in level of consciousness is really one of our primary indicators that someone's perfusion status is falling. And this would be a big indicator for me that the patient is not hemodynamically stable, that they are progressing quickly, and that we're likely going to want to move down this unstable pathway. The other piece that I'm looking at are signs of poor perfusion. So how low is the blood pressure? There's a difference between someone with a blood pressure of 80 who's alert and talking to you and someone with a blood pressure of 60 who's obtunded. Chest pain is a big one that I look for. So again, severity of chest pain often indicates how much ischemia this patient is having. So that could be related to their bradycardia. So because they're so bradycardic, they're experiencing significant ischemia. We also see in about 50% of patients that they're having infarction associated with their symptomatic bradycardia if they're presenting with an AV block. So again, when I'm looking at maybe the patient's in an AV block, they are a symptomatic bradycardia, so they're hypotensive bradycardic, and they're complaining of significant chest pain. I'm very concerned about their level of acuity or the hemodynamic stability. Pieces like shortness of breath, low SpO2 or low N tidal, and signs of compensation. So, do I see that this patient is extremely sweaty? They are breathing very quickly, and I still have that bradycardia and that hypotension. So, I'm seeing signs that compensation is truly failing. Again, my level of concern is going up. So, you're using all of these pieces basically to create a subjective picture of how hemodynamically unstable is the patient. Really, how much time do I have? Can this patient tolerate the time it's going to take me to get out atropine, give a dose, wait for it to work? And if I think no, if I look at all of these assessments and my answer is no, then I just go straight to pacing. So again, if the patient is hemodynamically unstable or they're at very high risk of progressing quickly towards cardiac arrest or cardiogenic shock because of their bradycardia, then we move right to pacing. If pacing doesn't work, we move to dopamine, and we'll talk about that kind of at the end. So what if they're not? So what if I look at this and I reposition the patient, their blood pressure is low, they're bradycardic, but I reposition them, I give a little bit of fluid, they're talking to me, but they're uncomfortable. They feel lightheaded, they feel a little bit dizzy, but I'm not seeing a lot of these signs that would indicate to me that they are progressing really quickly to a level of hemodynamic instability that I'm not comfortable with. So someone who's tolerating their bradycardia well, they're symptomatic, they are acutely ill because their blood pressure is low, but they're tolerating it fairly well. So they're hypotensive but compensating well. That's when we have more time. And that's when we'll consider usually atropine first. So remember, we have repositioned and given a fluid bolus to this patient. Then we can move on to our dose of atropine. Remember, atropine is going to be an antimuscarinic, or it's going to block our muscarinic receptors in the parasympathetic nervous system and hope to increase heart rate by allowing the sympathetic nervous system to work uninhibited. We'll do is we'll take a break here to take a look at, well, how many doses of atropine am I giving? Because a lot of time that depends on the rhythm the patient's in. So we'll take a pause here to look at, well, what are the different rhythms and why would I consider one versus two doses of atropine? So when we talk about what rhythms atropine may be beneficial in, or what rhythms are more typically going to respond to atropine, we can break them down into our more common bradycardias. So things like sinus bradycardia, junctional bradycardia, or atrial fibrillation. Again, this one is usually being the result of someone who's on a rate control medication. But a more typical bradycardia is not often the result of a blockage in the conduction pathway or disruption of the conduction pathway through ischemia. So in these rhythms, what was often happening is we're seeing one of two things. Is one, we can see a conduction disturbance. So for example, this would be the patient that you pick up who's in a junctional bradycardia. And the conduction disturbance may simply be that because of old age, we see a disruption in the function of the SA node, which is allowing the junction to take over. And then as a result, the patient is having the heart rhythm being generated at the junctional rate of 40 to 60 beats per minute. So it could be a conduction disturbance, so something that's preventing the normal upstream pacemaker from being what's generating the heart rate, and as a result, the heart rate is going to drop, and that can lead to bradycardia. The other thing that we could see is what is called altered automaticity. So something is going to be impairing the heart's normal ability to have automaticity. Or if when we look at our pacemaker, it's something that's going to change the rate and slope at which our pacemaker fires, which will then slow the rhythm. So when we look at altered automaticity, these could be things like drugs that the patients are on. This could be ion disturbances or electrolyte imbalances. Again, this could be old age, so someone who has an aging conduction system can all play a role. So all of these things can lead to an alteration in automaticity, which means that we change the rate at which our pacemaker is going to fire. And if we're slowing that down, so if we're causing the rate or slope of our pacemaker to decrease, then what we're going to have is altered automaticity and the rate rhythm can get slower. So this can be one of the reasons why we see sinus bradycardia. For example, this is one of the reasons why when we have increased vagal tone, we see sinus bradycardia, because we're altering automaticity. We're basically slowing down the rate and slope of the pacemaker. That's going to lead to a slower rhythm. So we're looking at things that can actually slow down the normal pacemakers, or conduction disturbance that isn't allowing will be our normal pacemaker from actually firing. Now, in all of these cases, we can't rule out ischemia. So we could see ischemia and infarction causing a patient to have these more typical bradycardias, but not as common when we're looking at these rhythms in particular. So if you see someone who's in a symptomatic bradycardia, and that's a sinus rhythm, it's not as common for that patient to be having infarction. Now, when we move over to our blocks, or third degree blocks, or our AV blocks, it's a little bit different. One of the most common causes of this is infarction. So when we're looking at these patients, about 50% of our symptomatic bradycardias who are presenting with blockages. So when we have someone who's having a symptomatic bradycardia who's presenting with a block, it's ischemia or infarction that's causing it. So that's a significant increase and something we need to be aware of. So 50% of symptomatic bradycardias who are experiencing a block, so that could be an AV block or third degree block, are having infarction as well. So these patients will, 50% of them will also have infarction. And that makes sense if you think about what's causing the problem. So when we're looking at someone who has an AV block, ischemia a lot of times is one of the things that is causing that blockage. So let's take a look at something like a second degree type 1 block. So I'll put up on the screen here an example of second degree type 1. We know in our second degree type 1 block, what's happening is our PR interval is typically getting longer and longer before we drop a beat. What's happening in these patients is they have a blockage within the AV node. So you can see here, I've drawn a blockage within our AV node. It could be here, it could be somewhere like here. Basically, what we're seeing is something that's impairing the normal flow of ions through, or the normal flow of conduction through the AV node. So if we look at what that causes or what that looks like, we know flow through the AV node is what's going to result in our PR interval. And what happens is our impulses are typically going to take the path of least resistance. So say this is our first impulse that's causing our normal PR interval. What happens is that tissue is going to go into refractory. And instead of being able to just send another impulse directly beside it, which would look very similar, we would see almost unrecognizable changes in PR intervals. What happens in this patient is, because I've got a disruption in the middle, the route continues to get longer through which I have to travel to try and generate an impulse. So what we can see in these patients is the second impulse has to travel a little bit longer around because it can't travel down that first pathway because it's in refractory. So the PR interval gets even longer. Our third impulse has to travel even further around, which causes a lengthening of the PR interval. And maybe now that our fourth impulse makes its way down the AV node, it gets blocked and we drop our beat. So this would be our dropped beat here. And this is how we get that kind of predictable rhythm in the second degree type 1, where we have the lengthening PR interval before we have our drop beat. And again, a lot of times that can be caused by someone having ischemia. Now, where things get worse is in our second degree type 2 block. This is where we have the drop beat is more unpredictable. So we have a hard time predicting that. And the reason for that is we typically have a blockage lower down. So in our second degree type 2 block, we have a blockage that's sitting at the exit of the AV node. And as a result, we have less room for passage of impulses. So what happens is I'm not really impairing the ability of my impulse to travel down the AV node. So my first impulse travels down the AV node and looks fairly normal in terms of PR interval. The second impulse would do the same thing. It's going to travel down a very similar pathway, and it travels down, and no challenges. Again, we wouldn't see a huge difference in PR interval here. Now, our third impulse makes its way down the AV node, but the path it would take is now blocked by ischemia, and we have our dropped beat. So we don't see a lengthening PR interval. We simply just have normal, and then a dropped beat. So this one would be our dropped beat here. Again, this is very common in people who have infarction. So infarcted tissue will often lead to this. And again, in 50% of patients who are presenting with AV block, we are often seeing them having infarction that are leading to that, especially those patients who are presenting with bradycardia that is symptomatic. So hypotensive patients who have bradycardia are presenting an AV block are often having infarction. So you can tell that the second degree type 2 block is worse here because it doesn't take much progressive ischemia to now block the entirety of the AV node. And now I'm headed towards my third degree block where I have no communication between my SA node and my ventricles. So a couple of things could be happening. So if we look at third degree block, what could be happening is we might have a blockage in the AV node like we have mentioned here. So the blockage could be here in the AV node. And what's going to happen in this case is we're not going to have the ability to send an impulse from the SA node to the AV node. It gets blocked here. So SA node will fire on its own, and we'll see P waves firing at their own rhythm, and we'll see a narrow complex rhythm being generated by the ventricles because somewhere up here is taking over as a pacemaker. Usually, the bundle of His or the junction is going to take over. So if the blockage is in the AV node, this is when AV node or above the bundle branches. This is typically where you will see a narrow complex third degree block. So we have a third degree block where the atria is not conducting to the ventricles. The ventricles are firing on their own. But in this case, we can have a narrow complex because we do have the ability of somewhere above the bundle branches to generate our impulse. So even if our ischemia is in the bundle of His, you could have ischemia in this area as well. So if we're looking at ischemia in the bundle of His, this patient too can present with a narrow complex, again, because the rhythm can still be generated before our bundle branches are branching off here. So we could have someone with ischemia in this area that would also lead to a narrow complex. Now where things get a little bit dicier for the patient is when we head down to ischemia lower into the heart. So the lower we go, it's less likely that an impulse is going to generate, the impulse is going to travel down the bundle branches at the same time, and this is where you get your wide complex. So we're looking at third degree blocks where the blockage is below the bundle of His. In these patients, what's going to happen is we're going to see a wide complex third degree block. So these patients will present with wide complex. So if we think about, well, what does this mean for us? So we just talked about the types of bradycardia. So we have patients who are presenting with a more common bradycardia that is often due to conduction disturbance or altered automaticity, versus patients who were 50% of them are either having infarction or the other 50% are having pretty significant ischemia or damage to tissue that's leading to the bradycardia that we're seeing. And we do actually see a difference in response rates to atropine in these patients. So in patients who are presenting with this more typical bradycardia, so I'm just going to label that up here as saying this is our more typical. What we see in those patients is they often respond well to atropine. So a lot of these patients will respond to the first dose of atropine. So when you're looking at someone who has a more typical bradycardia, quite often we're seeing that they are going to require less atropine, and the total dose of atropine that they're going to receive is actually lower than the other patients. So patients who have a more typical bradycardia, we find that they are more responsive to atropine. And again, typically require lower doses. So the repeat doses are much lower. So lower doses of atropine. And if you think about this, it makes sense from a physiological perspective because we know that atropine is going to be an antimuscarinic. So it's going to block the ability of our parasympathetic nervous system to fire. And when we look at parasympathetic nervous system innervation of the heart, so this is the parasympathetic nervous system here, this is the branch of the parasympathetic nervous system, it primarily innervates at the level of the junction and the atria. So if this is the parasympathetic nervous system, we're seeing it provide its function much more commonly in the level of the atria and then a little bit in the junction. So when we block the parasympathetic nervous system from functioning, so if we give something like atropine and we block parasympathetic nervous system functioning, we're more likely to take the brakes off of areas that are being impacted when we see a typical bradycardia. So when we look at these rhythms, the problem is that we're not seeing good conduction to the ventricle, we're seeing no conduction to the ventricle. These rhythms are more likely just due to slowing of the normal conduction pathways. So if it's a conduction disturbance or automaticity, if I take away my parasympathetic nervous system function, I can increase automaticity. Or if it's a conduction problem and I stop innervation of the parasympathetic nervous system, I can allow something like the junction to fire at a higher rate than it normally would. So when I look at these typical bradycardias, atropine is typically more effective because when I block parasympathetic nervous system innervation, the benefit is that I'm going to take the brakes off the areas that are firing slowly, and I'm going to prevent that altered automaticity from causing a slower rhythm. So hopefully I'm going to bump up automaticity and speed up the rhythm. Or if it's a conduction disturbance, maybe my SA node's just broken, it's not firing anymore, I can increase the rate at which the junction fires and try to push it past its typical rate and try to alleviate some of those symptoms. Now, that's not to say that in our atypical bradycardias that atropine is not effective. So, although it is less effective, it's not that it's not effective whatsoever. So, we'll call these, maybe just call these our blocks instead of atypical. So, when we're looking at the blocks, we see a little bit of a different response to atropine. So in the blocks, when you give atropine to these patients, what we typically see is about 28% of them will have a response. So 28% atropine will correct the problem. So in 28% of patients, atropine works. It's going to do exactly what we want it to do. In about 20% of patients, we see a partial effect. So we're not getting full of correction of the problem, but we see partial correction of the problem. So that leaves around the other 45 to 50% of patients, and what we're going to see in this case is no effect. And if we think about what that means for us in terms of treatment, this is the rationale behind deciding how many doses of atropine we're giving to people based on the rhythm that they're in. So if the patient is one of these more typical kind of portions or typical bradycardias, then we're more likely, if they're stable, to give 2 doses of atropine before we move to pacing. So we'll give the atropine time to work because we know that they usually are quite respondent. So we often see them responding quite well. Up to 80% of cases are actually going to see a response to atropine for in the more typical bradycardias. When we look at the blocks, we're more likely to look at maybe only 1 dose of atropine in these patients, because if it doesn't work, we're looking at patients who have the potential, or 45 to 50% of patients who may have zero effect of that atropine. So if you look at your ALS PCS and why it's written the way it is, this is why. When we look at these types of rhythms, we're more likely to see a response. Again, we're looking at somewhere around 80% of these patients are actually going to have benefit from atropine, and we'll see that correct their problem. The results are much lower in patients who are experiencing our blocks. So our second degree type 1, second degree type 2, and third degree AV blocks, only about 28% of patients will actually work for. 20% we get a partial effect, with 45 to 50 having no effect. So in those patients, if we think the patient can't tolerate the extra time that it would take to give the second dose of atropine, we can move towards pacing in order to do what's best for that patient. Okay, now that we're back and we have an understanding of was it 1 or 2 doses of atropine that we're giving to this patient, if that doesn't work, then we'll move to pacing. So basically, there's just a step in between when we're looking at the symptomatic bradycardia patient who's hemodynamically stabler than the hemodynamically unstable patient. So we decide how many doses of atropine we're giving, and then we would go to pacing from there. In either case, if pacing fails, that's when we move to dopamine. And when I say pacing fails, we might see one of 2 things. One is that we don't get electrical capture, which would be fairly rare in pacing, that we don't get electrical capture. What will be much more common is that we don't obtain mechanical output. So we attempt to pace the patient and we get no mechanical output. What that's telling us is that the patient is likely infarcted as well. So we're seeing some cardiogenic shock, and we're moving towards dopamine, which would support both the blood pressure, the output, and the heart rate. And we'll talk a little bit more about this in our next class.